is a game changer in my practice. Why? Because it has allowed me to more confidently, as a person, my team members, including resident doctors, nurses, and parents, to be able to better see what we did not used to see well enough before with what we use. And even patients who wouldn't ordinarily cooperate with tabletop camera, we're able to image them and be certain of what we are dealing with. It's a game changer. Every ophthalmology practice deserves one.
Welcome, everybody. Welcome, welcome. It is so nice to see you. This is the worldwide webinar number 6, Widefield Imaging in Pediatric Ophthalmology. Good morning, good afternoon, good evening, good night. I cannot tell you how excited I am to bring this program to you with my co-moderator, Dr. Lotte Wilander from Denmark. This is going to be a really exciting program. I don't think before there's been a webinar or a program where we've discussed wide field imaging right across the field, what's available, and we've got experts who use these individual instruments all the time. So let's, before we begin, it's been a pretty interesting time in the world in the last few days, and I thought it would be best to hear the words of a native American. Let us put our minds together and see what life we will make for our children. And that's what WSPOS is about. That's what these webinars are about. It's about the children and the patients that we look after. On that note, I want to remind you that season 2 has started. We are into obviously January the 9th, Widefield Imaging. These are all the different webinars that are going to run. I do want to make a special note. Look, Sunday, February the 21st. We don't normally do webinars on Sunday, but this is the WSPOS Strabismus Hall of Fame. Everybody who's given a keynote strabismus lecture at the World Congress meetings of Pediatric Ophthalmology and Strabismus will be on this webinar. So we are talking about Emilio Campos, Lionel Cowell, Richard Hurtle, Bert Kushner. This is going to be the opportunity to hear great names talk about great things. So make a special note for that particular webinar. So I want to thank you, our audience. You are amazing. Our WSPOS official channel has now got 2,700 subscribers. And since April, just the views on YouTube, we're not talking about Facebook, we're not talking about any of the other media. We have now reached over 70,000 views. This is down to you. Thank you so much. Okay, remember, WSPOS, free membership. There's a donate button. Whatever you can donate, it helps us make sure that we can continue to work with you because expertise resides all over the world. On that note, remember, we have a Mentimeter question going. This is the Menti code, 7879403, 787943. And that's the QR code. Oh my goodness, I'm getting messages right now. We right now have people from Egypt, Israel, Singapore, Sweden, Russia, Indonesia, South Africa, USA, UK. It's always global and it continues to be. This is your webinar, your society. Menti questions are running all the way through and we will give you the answers at the end. On that note, I'd like to introduce Lotte Wilander. Lotte is consultant at Aalborg University Hospital. She's the European Board of Ophthalmology Executive Board Member, and she is the Danish Ophthalmology Society Board Member and WSPOS Scientific Board Member. Lottie, it's going to be a great webinar because we're going to co-moderate it together. I'm looking forward to that. What can I tell you about Yining Struby, Director of Paediatric Ophthalmology and Adult Strabismus at Queen's University in Kingston, Associate Professor with tenure in the Departments of Ophthalmology and Pediatrics, Chair of the Continuing Education Committee for the Canadian Orthoptic Council, and she's a co-author with Ken Wright on his amazing textbooks, and also she's written the 4th edition of the Color Atlas of Strabismus Surgery Strategies and Techniques. Yining, welcome, and thank you so much for being here today. Jamila Hayasat, I'm very proud to introduce Jamila. Jamila completed her ophthalmology residency from the University of Jordan in Amman, in Jordan. She's currently doing a pediatric fellowship with us here in Pittsburgh, but I can tell you she was unanimously appointed as faculty at Children's Hospital of Pittsburgh and starts in July. And she has a special interest in pediatric anterior segment surgery. And it's a real proud moment for me to introduce Jamila as part of our faculty. So I'm going to hand it over to Lotte Belander, who is going to introduce the rest of our speakers. Lotte?
Well, thank you, Ken. And my co-host today is Ken Nischel, who is also the co-founder of the WSPOS and co-executive in SAME. He's the chief of pediatric ophthalmology and medical director of digital health at Children's Hospital in Pittsburgh, USA. And also in the executive committee of the WSPOS is Dominique Bremont-Chignac, who is born in Paris and a professor of ophthalmology and head of the department at Necker University for children in Paris and in the Rare Eye Disease Center. Furthermore, she is also the head of the orthoptic department of University of Paris and is a very active researcher and now president of the EVA Society. Thank you. And well, Dominique will be talking about the Optos. Just before her talk, we'll have Dr. Subhadra Jalali, who is presenting on the Trinetra NEOS system. Subhadra is the director of the Retina Institute and the Newborn Eye Health Alliance and quality director at the LV Prasad Eye Institute Hospital Network in Hyderabad, India. And for our final talk, we have Dr. Ashish Sharma, who will present his work on smartphone wide-field imaging. He had his fellowships in the United States and is now consultant retina and head research at the Lotus Eye Hospital and Institute in Coimbatore, India. He was awarded the AAO Award for International Ophthalmological Education and is an active researcher with over 80 publications. So I think it's a very exciting board we have here today, a panel, and please welcome Yining. If you will share your slides now.
While Yining is sharing, I'm getting messages from all over the world right now. We have Indonesia, Romania, we have Lebanon, we said UK, we've got Beirut, sorry, we've got Argentina, we've got Peru, Russia, Spain. If I haven't called your name out, I'm sorry, I will. Israel, Singapore, all yours, Yining.
Okay, are we good here? You can hear me?
Yes.
All right, thank you. So thank you very much for the kind invitation to this talk. Of great experience. I'm excited to hear what everyone else has to say. I'll be starting to speak about the Phoenix Icon system for wide imaging and pediatric ophthalmology. Let me advance here. I have no financial disclosures or consultants with Phoenix. So just as a quick background, I'm an academic pediatric ophthalmologist in Kingston, which is a tertiary center hospital in Ontario. We're not a children's hospital. I'm not a retinoblastoma center. We send our patients to sick kids in Toronto. And the background is for 3+ years, I was the only pediatric ophthalmologist in this catchment area of over 1 million. And we did not have any formal way of capturing retinal images. So after looking at our options at that time, it's probably about 4 or 5 years ago, we ended up trialing and being the first in Canada to acquire the ICON system. So many of you may be familiar with this, but just to go through some of the details. So it's a portable cart system as shown here. So it has a screen at the top here. There's the keyboard here, the handpiece and the holder, and this pedal with your foot for capturing images and image and gain. Our situation in Kingston is we have 2 hospitals that I work out of, one with the NICU and inpatient and emergencies, and the other is outpatient. So we actually have this unit and we transport it between the 2. I believe ICON also has a portable system now that wasn't available when we purchased this one, but I'm not familiar with it. So here we are. It's very easy to use. Again, I'm not a medical photographer, and so I found it. I was worried from advice from others that if you don't have a dedicated photographer, it would be hard to use, but I've been quite happy with doing it myself. And these are some just other specs. Obviously, it can take video, you can do video capture, and you can export the images either on TIFF, JPEG, or DICOM. So this is the handpiece, and again, it's very simple to use. It's lightweight. There's 2 filters here. So the white one is shown here, and then if you're going to switch to fluorescein angiography, there's a little switch at the top here, and then you switch the filter. So it's really straightforward to use. It's a single lens, 100-degree wide field view, and you can zoom live as well. And this is a screenshot of what the screen you're looking at looks like. What's quite nice for, again, someone like myself who's taking the pictures on my own, really with a resident sometimes helping, is there are presets. So if you have a light fundus or a dark fundus, or if you're doing fluorescein, the gain and the lighting and the intensity is sort of set for you. Of course, you can adjust that as you like, but it's a nice starting point. So for my particular situation, and in terms of, why we convinced the powers that be that we needed this machine, obviously for ROP, non-accidental trauma documentation, I found it very useful for documenting syndromes or progressive retinal findings. And really, it's wonderful, as many of these devices we'll be talking about today are, for collaboration, communication, publishing your results. So basically, we can improve patient care. So I thought I'd go through some quick examples, just real life. They're not edited, to show you, what my experience was. So first case was I had a 6-month-old girl referred with infantile spasms, agenesis of the corpus callosum, and asked to do an eye exam, which we get these referrals frequently. And this is what we saw. And we brought her to the OR during another sedated exam for other reasons. And this was the first picture I took on my own with no help. And was quite happy that I was able to capture this. And we actually use this in one of our textbooks. A second example is a baby I first met because of congenital ptosis. And as he got older, he was found to have global delay and hypotonia. And he was found to have a rare syndrome called Cohen syndrome. And here, again, are some examples of photos I was able to take on my own. With demonstration of these peripheral chorioretinal lesions. And then this is a fluorescein angiography to show the stains peripherally. So a resident and myself published this. Some of you may recognize Leslie McKean. She is an amazing ophthalmic photographer. And as I was looking back at this paper we wrote last year, I realized the top photos here were done at Sick Kids Toronto with the RetCam, and then this is at age 6 with the ICON. And both of them, I think, show nicely the findings we're trying to explain to our audience. This is another case where a patient came in, sensory exotropia, and to my surprise, had these findings at the back of her eye. And we initially thought this was a torch infectious related macular scar, but she ended up having these unusual findings around the retinal veins, which I wasn't familiar with. But my colleagues in retina in the States for this case were able to look at the photos and help us put the puzzle together. And this was presented in Paris, actually, 2 years ago now. And this is the same patient, again, fluorescein angiography. I recognize they're not perfect pictures, but this was, I believe, my resident helping me take them quickly in a busy OR. So we were happy to be able to narrow down our differential. This was a case, I may have shared this with Dr. Nischel, where, again, it's a patient with, I think she was 2-3 years old, sensory exotropia. I had no idea what was going on, but it looked bad, and we were worried about retinoblastoma. And, I was able to share these images very quickly with my colleagues at Sick Kids, Los Angeles, really anyone who could help me, because we do not have pediatric retina at my center. And again, quickly was able to narrow down the differential and get help for this patient. Again, we get a lot of referrals, question mark strabismus in a young patient. This patient had a exotropia, no fix and follow, and, very difficult exam. So she required a fundus exam in the OR. We got a quick glimpse and it looked like a morning glory disc, but we brought her to the OR to be sure there was nothing else going on. And this, again, was one of the earlier pictures I took. And although it's, again, not in perfect focus, I'm sure Leslie or other people with more experience later on would get this perfectly clear, but it nicely shows the difference in size, this glial tuft, and we use this for education as well. So my takeaway points for the outcome, I've been very happy with how easy it is to use. You need a coupling gel. We use tear gel, whatever's available in your country. It can sometimes melt, so you do need to use a lot of gel and be quick in terms of capturing your images. Personally, I don't like using the foot pedal. I prefer to have a nurse or a resident just help with the keyboard while I capture the images, but whatever your personal preference is. So easy to use, minimal training. I think it takes excellent images, and we've used these for papers, as I've shown, for textbooks, for collaborating with colleagues. It is able to take pictures of a wide range of fundus pigmentation and, of course, wide range of ages. And I found it invaluable and very happy that we were able to finally purchase this. It's especially helpful if you're in a smaller center. And I know everyone on this call is coming from a different situation. Especially with COVID, it's even more helpful to be able to communicate electronically, and helps contribute to our collaborating with our global friends and colleagues. So hopefully I've kept you awake. These are my kids. It's very snowy in Kingston. So thank you.
Fabulous. Thank you so much. Thank you. Yining, that's really helpful. That's really useful. I'm going to ask Jamila to start sharing her presentation. For the audience, clearly Phoenix Icon are a sponsor for this webinar, but we are discussing everybody's preferences and choices and what they like and what they don't like about the different types of wide field imaging that's available. So Jamila, if you'd like to put your video on and your speaker on, we look forward to your talk. Thank you.
Thank you for the introduction. I'll be talking about RetCam as a tool for wide field imaging. I have no financial disclosures. These are the 3 models of RetCam. I'll talk about RetCam 3, the model that I have experience with. As you can see, the system has a display monitor and the handpiece where you can attach and exchange different lenses with different fields of view. If you look at the back of the handpiece, you can see the diagram, which should match the patient position in order to make sure you're taking images in the accurate orientation. This handpiece can be slightly heavy, so a good tip while you take your images to put the cord around your neck that allows a better manipulation of the handpiece. There's the control panel where you can adjust your focus and your light intensity, and you can also take still images. The system also allows to take live video where you can take still images later on after you're done. Of course, there's a power source, light sources that we're going to talk about, a foot switch which allow a similar control as the control panel, and a printer where you can print out the images that you took. These images show pictures that have been taken by RetCam using lenses with different fields of view, 30 degrees, 80 degrees, and 130 degrees. Also, you can do scleral indentation while doing RetCam imaging, and here you can see the ora serrata using the scleral indentation. Also, it allows a feature of comparison of patient images of different exam dates. RED-free imaging is also available through RetCam 3. This system also equipped with fluorescein angiography in order to ensure clear fluorescein angiography images with early frames. First, you need to attach the green barrier filter to your lens piece, and then make sure that you have a good fundus view. And then you can transfer your light source to the blue exciting source and then take images. It's also advised that you take a live video and then take still images later on while you're doing your fluorescein angiography. In the next few slides, I will show you pictures and images taken by the RetCam for different pediatric pathologies. For example, this patient had familial exudative vitreoretinopathy. The picture on your right shows a fluorescein angiography where you can see the avascular retina with the vascular leakage. And the picture on your left, you can see a color fundus photo with the temporal dragging and the corresponding FA picture. Also, RetCam been used for screening for retinopathy of prematurity to document the anterior segment disease, such as poor pupillary dilation, and posterior segment disease plus disease, and different stages in different zones. Another example, in non-accidental trauma, these are pictures that document the retinal appearance and hemorrhages. These images is an example of a small peripheral retinoblastoma tumor that initially was messed with the indirect ophthalmoscopy and scleral indentation. And doing following RetCam images, we were able to pick up this tumor and the patient underwent treatment. These images are courtesy of Dr. Singh, which shows different retinoblastoma tumors. RetCam can be used to image anterior chamber structures and gonioscopy. For you to be able to do gonioscopy using the RetCam, first you need to use a good coupling agent and apply it on the corneal surface while introducing the lens and place it on the limbus opposing the angle you want to image, and slightly tilting the lens piece in order to visualize the angle. You can also adjust the focus and the light intensity for you to get a clear image. And these are pictures were taken using the RetCam. The picture on your left shows the iridocorneal adhesions. Another examples of anterior segment and angle images taken by RetCam. And here you can see the ciliary processes, the tube of a glaucoma drainage device the patient had. Inaccurate positioning of the lens, poor pupillary dilation, inappropriate light exposure, excessive pressure on the corneal surface can cause artifacts that will affect the image quality and your interpretation. You can get black shadow in the center of the image. You can get different light artifacts. Also, excessive exposure can mask some of the details of the image you are taking. This picture on your left shows the silver ring of the lens piece, and inaccurate positioning of the lens, holding it away from the eye, you can make this artifact. And this is different from the artifact you get if the patient has intraocular implant. With accurate and proper manipulation of the lens piece, you can actually have a better and clearer view of the posterior pole as the image on your right. 2 points to consider when using RetCam for retinopathy of prematurity. Excessive pressure on the corneal surface can cause the vessels to collapse and can mask plus disease, which can give false negative results that might delay detection in serious retinopathy. So care should be taken not to apply excessive pressure over the corneal surface. Another point, retinal hemorrhages been reported in a case following screening for retinopathy of prematurity. So examiners should be gentle and not to do excessive pressure on the corneal surface. Also, head immobilization in order to prevent sudden head movements that might lead to subsequent injury. So in conclusion, RetCam is extremely useful tool in evaluation of different pediatric retinal and anterior segment diseases, diagnosis, treatment, and follow-ups. And it requires adequate training and practice to avoid image artifacts and patient harm. And I would like to thank all my colleagues at Children's Hospital of Pittsburgh. Thank you.
Well, thank you, Jamila. Thanks for an excellent talk. And now, Subhadra, will you share your screens and turn on your video, please? And I think you have to unmute as well. Great, thank you.
Yes, thank you for having me here. And here we go on the forest Trinetra.
So while we're waiting for this, oh, there we go. We're ready to go. Thank you so much.
Okay, so I think some people may be thinking, what is this Trinetra? So Trinetra is the third eye of Lord Shiva, whose right eye is the sun and left eye is the moon. And he opens his third eye, which represents the fire, when he has to do something great. And I was surprised that there's actually an article in British Journal of Ophthalmology on Lord Shiva's third eye. So those who are interested can go through more details about that particular eye. But here we are looking at that if you Google search the newborn fundus imaging, there's so many fundus cameras now. You have so many choices. So why do we need one more? And where does the neo-forest imaging stand in this very emerging field of pediatric retinal fundus imaging? So I started my fundus imaging with the indirect ophthalmoscope video. This was the one which was quite inexpensive at that time. And I still believe that it gives great images. I have published these images because it is stereoscopic and no other camera is stereoscopic. So you really get very high resolution images for less expense. But, there have been so many advances in the camera. I have used RetCam shuttle. For a short time, I used the MI RetCam. But it's the Forest Neo, which I'm using now. It is made in India, in Bangalore, which is the IT capital. It is sold in USA, Canada, and Europe, and maybe in other countries. I also have my own small camera, which is a small otoscope, which can be used. So this is just to show that, there are so many cameras that we can use for the screening. So why I shifted from the RetCam shuttle to the Forest was its cost. It costs around $2,500 to $3,000 US as compared to maybe 12,000. But more important is that for, a delicate darling like me, I cannot move this big shuttle up and down my NICUs where there may not be an elevator. We may have to go up the stairs, and this needs to be lugged up. You need a special vehicle which will keep it vertical up when you're moving it from your one center to another. So really, I think it's quite an outdated technology with such a big CPU. When you have small cameras in the phone, why do you need that big CPU? So really, we wanted to see a small handheld, really portable camera. And I'm happy that I designed some of this bag because the company came with a huge suitcase. I just threw it out and said, I'm not even going to try it. So now we have this really portable, lightweight, a very ergonomic handpiece. And it is a cabin luggage size bag, which fits everything. And it also gives you a good 120-degree wide field image. And this is from the company website. Of course, like any other good imaging device, it is DICOM compatible, telemedicine. You can have still images, you can have videos. But the good thing is that it's very light. You can see the handpiece is only 340 grams. So it really doesn't blanch the retina. It doesn't cause hemorrhages, as we have seen sometimes with our heavy RetCam. So how do you know that the images from the RetCam or the Forest? So you can see they look almost similar, but the RetCam images are cropped on the top, whereas this is all round and it has no background. So that's how you can immediately know which images from which camera usually you can make out. So it can give you very good images which have good resolution, but this depends on the refractive error and the color of the retina background. You can also have a tool which you can move on the image and you can magnify a particular vessel or a particular area, so you can see these areas more clearly. You can see each vessel, or you want to magnify the new vessels. Is it a front? Is it a shunt? So that can be done right on the machine. And then you can, of course, export all the images on your smartphone. You can send it to the patient. You can send it by email. These are all, easily done, I think. But what I like most about it is that you can do serial photographs and you can really see how the disease is evolving, what is happening. This is, for example, a published paper that we published this year on bleb-shaped things. And you can see, most of the things are visible. You can see the scars, you can see the vessels, you can see the elevations, blood, quite well seen. You can also make a collage if you want to do more. You can do that with this machine. The interesting feature in this camera is the image enhancer. So because there can be different types of eyes and different background, but most important is, sometimes the vessels are very sparse. And this is a very severe APROP, which is quite common in our country, where there's a lot of unmonitored oxygen. And also if the baby is on oxygen, and especially if the baby has received anti-VEGF, then the vessels become very narrow. And if you want to see them very clearly, then you can use the image enhancer, and then you can, map out or measure each of the vessels and their shapes. And you can do serial follow-ups and, decide and show to the parents why you're doing certain things and why you're not doing other things. So my experience in this is that it's very, very useful in rural areas, in urban NICUs. We just pick it up like a small bag off the shelf, and we can go in any car or any bus or any train and just go anywhere with it. Both in the outpatient and in the OT, it's very useful. It integrates very well with our EMR and smartphone teleconsults. There's no pressure on the eye of the baby. And we have a very good tool. It has already been validated. There's a validated certification process of technicians. And so now the non-physician graders can use it, and they can be certified that they are now, well within their reach to go and screen the babies. What are the problem areas? One of the things is that it's very specific for newborns. It's not for older children. In pseudophakic eyes, or when the children are older, it becomes a little difficult to focus it. I hope this problem will be solved in future, but because it is specific for newborns, that's why it has high resolution for those babies. The other thing is something which, people like me who are not very tech naive, we are very tech naive. I don't know how to use it. Sometimes, if I have not shut it down and I start entering the data, it takes in all the data very nicely. And then when I start taking the picture, it doesn't take that picture. And then I have to say, oh my God, I had to actually shut it down and start it. So look out for our review article on pediatric retinal imaging, where we are discussing all the cameras. And this is already in press. It will come in the Indian Journal of Ophthalmology in a few weeks. So the future advances, I'm very happy that NEOFORUS, because it is being made in Bangalore, which is the IT capital, not only of India, but for large parts of the world, they are really going all way to make it artificial intelligence and deep learning enabled, so that there's a computer self-analyzed reports which come. Currently, it's only a diagnostic tool. It doesn't self-analyze the images. And then use it beyond infants, as I said. And of course, it's already on the way to have an FFA with it. So this is just the picture with my handheld small camera, which costs less than $500. And you can get images from so many ways. But what I want to say in end is that the best in the eye cameras is yet to come. We need not only the Trinetra, we need the fourth and fifth eyes. I think camera technology is so advanced that I'm sure we are going to have very good cameras within a couple of years. Thank you. And I want to thank all my technicians and my fellows who helped me to take all these pictures. And I'm happy to answer any questions.
That's amazing. So far, 3 amazing talks. If everybody can put their videos on, we have some time for discussion. Before we get to the discussion, firstly, thank you everybody for keeping on time. I'm getting rebuked because there are countries I haven't mentioned. So France, sorry, Dominique, of course I should mention France. France is here, Ethiopia, the Philippines, Romania, Nigeria, Ireland, Mexico, Kazakhstan, Italy, Saudi Arabia, it goes on. So
you have to say India. You didn't say India. Okay.
Okay, India. All right.
Okay.
Lottie, I think we've got some questions, right? So let's open this up to the panel.
Yes. Well, Subodra, my first idea was, can you use this under anesthesia for children that are older than the neonates? Because I guess both ICON and RetCam, you would have to do anesthesia to take pictures of older children.
Yeah, so for older children, we can take, but it's not as well focused. And you may have to use some lens or something, but I don't use it for older children. Actually, for most of the older children, I use the Optos and I use the RetCam shuttle, which is in the hospital. Most of the forest I use for, taking it out and for a quick work in the outpatient department and even under anesthesia for babies. But for older children, and especially for our retinoblastoma children and our children where they need an FFA, I don't use the Forus.
Okay.
As I said, it's very good for newborns and ROP screening and taking it out.
And Yining and Jamila, how old are the kids before you start taking pictures under anesthesia?
Anyone? Yining, Jamila?
So it can be used obviously when the babies are awake for ROP. I've used it I don't usually bring a child for an EOA just to take photos of the eye, but often the children I'm taking photos of for a variety of reasons need a sedated MRI for their brain or otherwise. So there's really no age limit for me. It's usually just more dependent. I think the images I showed you, children were under 6 months, but it wasn't because it couldn't be done. I hadn't attempted to do it awake in those children. No. I think it'd be challenging. Personally, I found it challenging just with the older ROP babies because they move if you want a really crisp image.
Okay. Yeah.
Jamila?
Yes, yeah, I have the same experience. Depending on the pathology, and if the child is brought to the OR under anesthesia, you can use the RetCam. I don't see a limit for age to use RetCam.
So we have one question, and I'm assuming the answer is yes. If you can use the RetCam for anterior segment, I'm assuming Yining, you can use and Subhadra, you can use the Trinetra machine and the Icon for anterior segment as well, right?
Yeah.
Yes. There's a special filter on the Icon. I forgot to mention that, like a diffuser, and it allows you to take anterior segment photos. I've used that occasionally.
I have a question with Dr. Subhadra and Shub. How are the indentation with Trinetra and the Icon?
Yeah, we can do indentation with Trinetra. There's no issue with that.
No issue.
Yeah.
Okay.
So I think what was really interesting, and I'm going to pull in Dominique on this discussion as well. Let's be clear about this. The RetCam machine has been around for over 20 years. I remember in my fellowship in 1998 at Sick Kids, Leslie McKean was the photographer at that time, and I remember seeing the RetCam for the first time. Then that was RetCam 1. Then RetCam 2 came along and RetCam 3, and somebody's asked a question: why are the images so much better on RetCam 3 than RetCam 2? And I would say it's the same reason why the images in the Icon, I haven't had any experience with the Netra, why they're better than RetCam 1 and 2 as well. And perhaps even RetCam 3. I mean, that's up for debate. It's just the technology's got better, hasn't it? Isn't that the only reason? Our optics are better.
Yeah.
I think maybe the technology is much better for sure, because we have more really the optics, the quality of the optics are probably better, but also of the informatic, I mean, for the computers. And also maybe we are more keen to do the examination because we know how to manipulate, and maybe that's the answer.
Yeah, no, but also I think some of the technology is different. For example, in Trinetra, they don't use optical lens; they use a liquid crystal lens. It's a little different. You get an image, so it takes a little training because it's not a flat lens. It's like a globular lens. It rotates like a globe, so it's a little different. But that gives you the wide field with a small lens.
So, can you do fluorescein on the Forus, the Trinetra?
Not yet. I think they're going to release it this year.
Okay.
Yining, can I ask you, you showed a very nice image. Was that ICG that you were showing, or was that fluorescein?
No, that was a fluorescein, just I didn't use the black and white image. Okay,
I see what you mean. So
I don't do ICG with it, obviously.
No, I don't think any of the systems you can do ICG. We're going to be talking about the non-contact ones as well. I'm not aware that Optos or Clarus or actually there's one other contact one that Lotte is going to talk about, which is the Panocam. Before we go on, I just wanted to make clear, we did some investigation. Every single device that was being talked about today is FDA approved. Now, we did not go to every country in the world and see if the local institutions or the governments had approved every single one. So please check in your country whether the system is approved for use. But every single one we're talking about is FDA approved for ophthalmic imaging. So that's worth knowing. Lottie, any other questions that are coming up?
Well, there's also a question from the audience if anyone has experience with the EPIC. EPIC. I have never heard of it. Okay, so I think that's an electronic medical record. And I think the question there is, so Dr. Liasis, who works with me at CHP, he just put on the YouTube channel, he said, one of the problems that we have is that if you want to take the image and have it immediately put into an electronic medical record, it has to be in a DICOM format. And what happens is these companies apparently are charging for that actual ability to do that. And I think that, and I agree with Dr. Liasis, he puts on the chat, we should all lobby these companies to make that DICOM facility part of the actual product and not an add-on. Because if you have EMR, it's much nicer just to hit a button and have all the images taken into the patient's EMR. Can you do that at the moment, Yining?
We can do it on the Trinetra. We do it. I don't think the company is charging us, to best of my knowledge. Yeah, we can do it directly. But it does say that this facility is country specific, because if in a particular country they don't allow certain things, then they will not give this access in that country. So
no, and the problem for Europe is that you are not allowed to use cloud-based solutions for transferring pictures. You have to use it either an USB or you have to use some local network. And that's a problem with all the machines.
Right. Jamila, here at Pittsburgh, we are able to use the DICOM facility, right?
Yes, yeah. So with RetCam, it allows you to store the images in JPEG and DICOM, and you can export it to Drive, and then this can be uploaded to the patient chart.
So I'd like to take the conversation in another direction. What I liked about the Phoenix Icon, which I've trialed, you can detach it. So it's not attached, the one that I used, by a cord. Is that right, Yining?
The handpiece is attached, right, but it's like there's a cord. It has to connect to the computer, but it's lightweight. So similar to what Jamila was saying, you know, we put it around our neck probably just because that's what we've done with the RetCam, but it's not wireless or. Okay,
I was under the impression the one I tried, maybe it was a prototype, that you charged and then you could take it away for about half an hour. But the other thing is it's light. Has anybody tried all three to give us an idea of how heavy that handpiece is?
Yes, I've been trying all of them, and but I will not say anything before Lottie just present the Panocam, because this is a lighter and also you can use it without any wire, any cord, and I think the quality is very good. I've been using Nitra, I've been using also, and that's why I do prefer this one. But you know, also it depends how you use it. And we are in a hospital that we walk around, and so it's so easy to have only the handpiece, and so you come back with that, and so there is not a lot of stuff to go with you.
Which machine is this, Dominic? For clarification, which machine are you?
Panocam, but Lottie will present it, so I think it will be better after to discuss that.
Okay.
And it's just because the handheld piece is very, very light.
Okay. Now there are a lot of questions coming in, right, Lottie, about the cost. It's impossible for us to start discussing costs because they do vary around the world. But I think that by listening to a webinar like this, you should be able to negotiate better when they come to a cost and say, well, actually, I do know that there are 4 other products. So that's, I think, hopefully helpful. Lottie, any other questions? There are a few other questions coming over at the moment. Would you like to take some of those and share them with the audience?
There's one about the pedals of the RetCam, and we've had a RetCam too with the same problems, that the pedal and all the plastic wires are really a soft point for this this machine. Do you have any comments about that, Jamila?
Yeah, so I've done like examination under anesthesias and had to do the RetCam images by myself. And I mean, it's not as easy as the control panel with someone else helping you focusing the images and the light intensity, but it's like doable. You can control the focus and control the light intensity and take stills too.
Yeah.
So,
okay.
yeah.
But it is a softer spot on the Icon Go, or no, the shuttle, definitely.
Mm-hmm.
I mean, I don't tend, if I'm lucky because I normally have somebody with me in the OR, and I prefer to use the actual controls, leaning like you do, rather than using the foot pedal. So, but you do need somebody with you to do that. Okay, so I have, this is a really interesting question. Manoj Paralekar, a great friend and a superb pediatric ophthalmologist, is listening, and he says, excellent session so far. Thank you, Manoj. We have difficulty with light metering with the RetCam 3. Especially with calcified retinoblastoma tumors, the periphery gets bleached out. Any tips or tricks? And before we go to Jamila, because we have this problem too, Yining and Subhadra and Lottie, the other machines, they have an advantage, I think, in this aspect, right, Yining?
Yes.
Anyone?
I've not had issues with that, but again, we're not seeing volumes of retinoblastoma, but I've not found that to be an issue as of yet.
But on the Phoenix Icon, you can change the gain and the intensity, right?
Yeah, that's I like that a lot. It allows dark fundus, light fundus, peripheral, so it's not been an issue yet for me.
Right, but see in RetCam, you've only got light intensity, and if you make it too low, you can't see enough, and if you make it too high, it blanches everything. So I don't really have a tip or a trick. Do you, Jamila? And then we'll go to Subhadra to tell us about the Netra. Any tricks about this blanching effect?
Yes, I think you can just take 2 pictures, and after that you can merge them, and that's why we do that. When we have this device, but that's, of course, you need to take 2 pictures, but it's quite easy.
Subhadra, I'm going to let you have the last.
So in the Trinetra, you can enhance, as I said, you can enhance the features after taking the picture, and you can do the same thing, that you can make a collage, take different pictures at different intensities and do it. But also in the RetCam, when I was doing, you also have Photoshop there in the RetCam itself, where you can, change the colors, and you can get decent pictures, but that's all post-processing.
Perfect. Jamila?
Yes, so as you're saying that RetCam allows you to edit the image after you take it. I have no experience with retinoblastoma images, but different pathologies can, with more light exposure, can mask some of the image features. So adjusting the light intensity and edit the image after can help in detecting and get better images.
Well, this has been great discussion. Lottie, would you like to introduce the next speaker?
Well, yes. Well, actually, Dominique, if you will share your screen, where you're going to talk about the Optos.
With pleasure.
Thank you.
And so I will talk of something quite different, because Optos is something different. I'm sorry. Okay. It's a tool for wide field imaging, and this is quite different because we use it in consultation. So,
Dominique, I don't think your slides are on yet.
Okay, I was supposed to. Okay.
Thank you.
So you have that, but
that's it. Yeah. There you go.
There we
Well
go. Okay. Okay, so that's good. So sorry for that. And so Optos is really a different tool because it's for wide field imaging and only in consultation. So it's a different tool. And the question is, why do we need to perform ultra wide field fundus? Because you have a larger field with dilation or even without dilation, and it's a quick procedure for children. It could be done for very young children, and so can you know it? Because when you went to Paris, you use it, and we use it for 8 months old child, and also there is no chin rest. So you can see here, the the very, very wide field because it's 200 degrees. So you can see the device, and it's a very sophisticated system with laser and a very wide mirror. And this is very good also for eye screening. And you can also have fluorescence imaging. You can have the acquisition in less than half a second. So for children, it's very, very comfortable. And you see here, you have the machine, you have a special screen to acquire the images, and you have a screen also. In this screen, you can see the photos you have done. So just here, it's not a very, very young child, but you can see you just put the head on the device, and they look at a blue or green or red light. And when it's green, it's good, and you can take the photos on the screen, just touching the screen. And so the question is, just a quiz, is this fundus normal? It could be normal when you just look at that, but take a very wide field. No, there is a very hypopigmented retina, and it's an albinism. So that's why it's interesting to have a very, very wide field, because the diagnosis is very different. And there was also a foveal hypoplasia that we see in albinism very often. And it was a genotype with also a gene mutation, and this child has low vision reeducation and iris transillumination, as you can see here. And also in an iridia, for instance, you can see the mother here, a very variable phenotype, and the child with a complete aniridia, and can see also macular hypoplasia. And if the image is just blurred, it's because of the cartwheel cataract we often see in PAX6 mutation. We can see also lesion in a peripheral lesion, and also retinal detachment. And if you just see at the first image, you can see here the retinal detachment, and just very, very near the macula. And this was operated in the same day, of course, to be sure to have the best results. And you can see here laser on the right image, and white also in the low image. We can also see for the optic nerve, and you can see glaucoma. And if you just go, you can just go very, very close to announcing, for instance, the optic nerve, and you can see how the disc is, the cup is very, very intense. And in the other, you see a globoma in both sides. It can be useful also for RP65 mutation in Leber, congenital amaurosis, and we know that at the time now we have a possibility of gene therapy with Luxturna, and this child was operated here with an injection, a subretinal injection, and after that we have postoperative results. And we have some patients now, and one patient just recovered 2 lines improvement, which is really very, very important for us. And so I would like to thank you for your attention. I think really Optos is easy to use for children, is adapted in consultation. It's a quick procedure, an ultra wide field for 200 degrees. And so use it and you will see that it's really simple. And just from Paris, countries of ERNI and rare eye disease. So thank you very much for listening, and have a great time also.
Thank you so much. I have to tell everybody that I was very lucky to be invited by Dominique to her wonderful hospital in Paris 2 years ago. And she showed me how she used the Optos. And when I got back to Pittsburgh, I insisted that we got one. It really does change practice. However, there are other machines that do wide field, and we're going to hear about those now. And we're also going to hear about another contact wide field. So it gives me great pleasure to introduce Lotte Wilander. Lotte, if you'd like to share your screen.
Thank you. Let me see. Here we are. And let's see, here we go. Well, thank you very much, Ken. And I'd like to talk about the Zeiss Clarus 700 and the VisuNext Panocam system. This system is definitely not portable, but can be a bit scary for the kids to sit with as well. So we usually start our pictures with something like a teddy bear. And I'd like to say I have no financial interest in neither the Clarus or the Panocam that I'll talk about in a little while. The pros and cons of this system. The pros would be very good sharpness and very good detail. It's multi-purpose, and once the child is in the chair, it's easy to focus and get very good shots. And it has beautiful colors, as there are photos and not, like with the Optos. The cons would be that this is an expensive apparatus, it's not mobile, and it does have quite an intense flash. So you get one good picture of one eye if you're undilated, and then perhaps not as good on the second eye. And for this, you need a dedicated staff. It's hard to get pictures of the extreme periphery of children. Our typical montage would be something like that. We use it down to 2.5, 3-year-olds. And again, first Teddy and then the eyes. And this 3-year-old girl comes in for a CMV control. And notice that it only takes 1 minute to do all 3 shots. We use it for follow-up of several patient groups, but also discover things that we don't find with indirect ophthalmoscopy, like in this 9-year-old von Hippel-Lindau patient, where we discovered a retinal peripheral hemangioblastoma. And now we can follow him regularly and see that the lesion luckily hasn't changed. We use it a lot for ROP follow-up, especially for treated children, but also the ones that weren't treated and had ROP. And here, as I was mentioning, it is hard to get pictures all the way out to the laser scars. You can see that zone 1 and 2 is actually fairly well covered, but still we don't get the far periphery. And you can take pictures of children that you normally would have problems with using the, for instance, Top Gun or other with automated features, as this 6-year-old boy with developmental delay, attention deficit disorder, and vessel dragging due to his ROP and treatment. Here you can see the vessels dragging easily, and with him I would not be able to get this close look. But the thing with intense flash is that often you get one good picture on one eye, and then on the next eye they get a little bit flash feared, and you have to puzzle the whole fundus together yourself after what you can get after this. We use it for diagnosis as well, like this 8-year-old girl who came in and looked very much like a Stargardt patient, and you can right away do the autofluorescence pictures and see the flecks around the arcades. But the flash in the autofluorescent pictures is quite intense compared to the spectralis that we otherwise use for autoflu pictures. Another group of screening would be like the Stickler patient who's only 3 years and minus 15 diopters myopia. He doesn't have the attention span to sit for a prolonged investigation of his periphery, but here with the pictures, you get all the details in one shot, and you can be assured that there are no retinal degenerations or tears. Also, the magnification works wonderfully. This is the same picture in 24% and 160%. We have the fluorescein angiography component as well. This was a 10-year-old boy who had a decreasing vision in his right eye and a decreasing peripheral vision as well. And we wanted to take the autoflu pictures of him first, but he couldn't participate in this because of the light intensity. But he actually managed quite beautifully to have his fluorescein angiography taken in the Clarus, because as we do a fluorescein angiography in this machine, it's a milder flash than the Heidelberg spectralis we otherwise would use. And you can see excellent details at 28 seconds with vessel filling, and at 6 minutes there is no leakage, and you even get a good shot of the choroidal vessels. So these would be the pros and the cons. And comparing it to the Optos, which we do not have, but we've had it on loan for a few times, the photographers thought that it was harder to get the children to actually accept having the pictures taken. You get more eyelash than pictures, but of course the field is wider as the Clarus only goes to 100 degrees. And I'd like to thank our photographing staff, Tanja Kiep Jensen, Linda Neumann, Hanne Garda, and Anita Christensen for these beautiful pictures. And moving on is the Misonex Panocam Pro and Solo systems. 2 Danish eye departments have acquired these for ROP screening, and they are very content. They haven't had it for a long time, but it's very transportable and then handy for going to different wards for your ROP screening, and you get the screen directly on the handle, which to me sounds like a plus, because I usually RetCam screen on my own. I have a nurse who helps hold the head still, but still you have to focus on both the hand, what you're using with your hand, looking at the screen, and moving your feet at the same time. And these pictures are taken by Bettina Lehrmann at Vejle Hospital, and what they show is the screen, which is quite small really, and handy and not heavy according to her, and the joystick button that you can use for light intensity and zoom and taking the pictures, and you can see the eyepiece is pretty much like the RetCam icon and others, and you can see the suitcase with the apparatus, so it's quite easy to use. And these are pictures directly from the screen of the Panocam taken with a smartphone, because as I was mentioning earlier, we do have a little bit of problems in Denmark as to how we transfer pictures from the photographing machines and to our hospital digital photo system. This is another example where you can see Rich in this picture with a stage 3 peripheral Rich, which is actually quite central, not peripheral. So thank you very much for your attention. And let me unshare here.
That was remarkable. Thank you very much, Lotte. I think I think we have some time for discussion. There are loads of questions coming in. Can all the panelists, Ashish included, can you give us your tricks for examining babies awake? So even if you don't have an Optos, you don't have a Clarus, what do you use and how do you do it when you're examining a baby awake? So I'm going to kick off with, I'm going to ask Jamila, when we do the Optos, which we have, what are the tricks for the really young babies that are being done? Any advice? Or anyone, really?
So we can use the flying baby technique, where you can put the baby on your forearm and basically stabilize the head and move it like forward toward the Optos, and this helps take good images of very young children.
Yeah, and I think C.K. Patel has published this widely, C.K. Patel's flying baby technique. There was a question about that a lot of what the people are using, a large group of children that they want to image are the post-Avastin ROP babies. And I think that CK's written about the flying baby technique. Subhadra or Yining, anyone, any advice?
Yeah, we are doing regularly all our outpatient on the Optos. Before, after, it's quite convenient. You have to put the speculum and flying baby, and we also learned from Patel, and we are doing it regularly. One of the interesting things which helps, which doesn't somehow come in other cameras, is what was shown on the Optos, that you can get the superimposition of the media opacity. And that's very helpful because you get the cataract or the PHPV cataract or a corneal opacity right on the macula. And so you can know whether this opacity is really on the macula or it's peripheral. So you really don't need to, go ahead and imagine or do your retinoscopy and, have the child look at it. It's even for the small cataracts of retinitis pigmentosa, the stellate cataracts, they come out very well on the Optos. So, that's really helpful. If there's a corneal scar, it just superimposes and you can make out where that opacity is superimposing on the retinal fixation point. The other important thing for the babies, because we do, few days old babies, 20 days babies, is that they must be well fed and burped. And you can use a sucker, you can give a small, this sucrose pellet and make sure the diaper is done. Once they're comfortable, they really are better than any other older patients. They just follow what you tell them to do and keep on talking to the baby. Don't think like, there's a patient and I need to talk to the machine. So talk to the baby, it gets calmed down. Be like that mother there, just talk to the baby or tell the mother to keep on talking to the baby, because even tiny babies, they recognize their mother's voice. And then the babies are calm and you can take as many pictures. We don't anesthetize for pictures. We take them all the time.
Great tips. Ashish, what are your tips?
I second completely, Dr. Subhadra.
Okay, that's fair enough. Dominique, Yining, Lotte, who wants to take that? Go ahead.
So we're lucky enough to have an Optos, and I've tried the flying baby with success. Definitely swaddle them and have a nurse who is not afraid of babies. As I said, we're not in a children's hospital, so you have to find the right helpers. The sucrose and the feeding is, I would say, is key. We've done the oral fluorescein as well. We don't have the Clarus, but we have the Visucam, which also takes lovely photos. So I must say, maybe being older school, I like those better than the Optos, but the Optos is amazing for the periphery. So I don't know if there's any tips for how to get over that greenish hue, but the Optos is great. So, I mean, I agree. We've got 2.5, 3-year-old kids who can get beautiful photos. You can do even younger.
Dominique?
Yes, I agree. I think sucrose and with babies lying, and I think you don't need every time an anesthesia. We do it without anesthesia also. And Optos is a really great technology. And when we know the story of the Optos is because the engineer that built this one is because his child has a retinal detachment, and he said, I don't want to see that again. So that's really a very interesting technology and very very sophisticated and easy to use for sure, non-contact. Yeah, right.
Well,
Lotte, can you talk about the Clarus? I mean, just for everybody's information, look, the difference between the Clarus and the Optos is the Optos is artificial colors, right? The colors they're created by the machine. Clarus is real color,
Fundus.
real fundus color. So there is that difference. What have you tried both, Lotte? Have you tried the Clarus and the Optos?
Not a lot. We've just had it for a few months, the Optus, and not at the same time as the Clarus. But the photographers were feeling that it was harder to get pictures with the Optus. They were scared of putting their face all the way into the camera.
Interesting.
That's interesting.
We don't have that experience. That's interesting.
That's really interesting because we don't have that. And just a tip you can use for Optos, you can take out the tap. If you take out the tap, you have only the mirror, and sometimes it's easier with the children. And probably the image and the quality of the image and the colors is better with the Clarus for sure. And it's just probably you need to be used to see the colors of the Optos. And I understand that it could be something disturbing to have this kind of colors for the first time. And but when you see a lot of these images after, it's quite easier. You have just a learning curve, I think, but it's quite easy.
I'm positive that you're right, and I would actually love to get an Optus to get the very peripheral shots.
But a couple of questions that are coming up, and I think they're all very relevant questions. What do people? If you had a choice, if you had a protocol that you wanted to share with the audience, could you, Subhadra, we're going to start with you. You've got a 2-month-old baby, has ROP, and he's 2 months, out of the last treatment, and they had Avastin. What are you going to use? Are you able to use your Forest on that child, or are you going to use Optos?
I can use both. They will give equal information to me. So if my focus has gone to the rural area, so we use both in different ways. If it's in the outpatient, I may not have Forest there on that day because it's gone into the rural area. But if it's there, then I might use that. So either it will give me good images on both, right up to the periphery, because under 20 degree, yes.
So Dominique, let's say it's a 6-year-old. What are you going to use?
I should say that you can. The problem is you don't have all these devices. That's not a possibility to have maybe all of them. And I think you can use them, all of them. It's also something very important is that you be used to your machine. I mean, when you are used to a machine, you use it very well. I think use it at the best. And for sure, if you ask me for ROP, I should say probably Panocam, and I have no interest in it. But I think it's just because it's portable, very easy to use. I really like Optos for consultation because I think it's much better also, but it's a different device. But all of them are good. And some of them have better definition, and so it can be very interesting also. I really wish to have all of these machines, but I need a larger department. And I don't know, but the hospital is not okay for that.
So, Jamila, I'm going to close with Jamila before Lotte, before you introduce Ashish. Jamila, I think that our imaging department have created a game that they play with the children. Do you know about this when they're doing the Optos?
So they let the child take their own images. And this is like really encouraging for children. So they can get closer. They feel they are contributing in taking images. So I think they are more encouraged in cooperation and taking images.
The Optos pad looks like an iPad on its side or a tablet. And so Dr. Liassis and the imaging team have created this game, and the children are actually taking their own pictures. And it's really, we can get them down to 2.5, 3, and they think they're playing a game. So it's really, really interesting. Lotte, would you like to introduce Ashish, and then we'll have more discussion?
Yes, well, thank you very much. And Dr. And Ashish, please, if you will turn on your slides and tell us about smartphone digital imaging.
Perfect.
Very good. Thank you.
Okay. Is it visible?
Yes, you're good. You're good.
Yes.
So first of all, thank you, WSPOS, for having me here. And it's an extreme honor to be a part of this wonderful program with the wonderful faculty here. So I would be talking about the smartphone-based wide field imaging. And these are my disclosures. I do have financials and the proprietary interest to disclose in RetCam, which I'm going to talk about. So if you look at the editorial by Adams, which he has written and published in I think last year, and he is talking about the ROP in Asia and what is the best way forward. So if you look at him, and he has mentioned all the devices, and even he has mentioned the Trinetra, and he has clearly said, although you have technological advancement in the developing countries, but still, if you really want to take ROP to the next level and try to take it really going each and everywhere, the screening, then smartphone imaging is the one which can do that for you, provided few things are sorted out. Similarly, if you look at this paper by the Antaki, they have also mentioned the same thing, that the way a smartphone-based technology can help in the telemedicine, it can really alleviate the anxiety or burden on the healthcare system as far as retinopathy of maturity screening is concerned. And this is the paper that we published, that yes, we are excited. And there's a lot of work is happening on the smartphone-based imaging that we call it as an SROP. But there are opportunities, but simultaneously you have a lot of challenges also. So to streamline, basically you have 3 commercial devices across the globe, which are very well published, very well tested. So this is the device which we call as RetCam, and this is the device that we have designed around 5 years before. Until now, with the help of a lot of contributors across the globe, there is a lot of papers, around 6 papers published in terms of testing each and every aspect of the device. And apart from this, a couple of other devices. One is Paxos scope. Recently, last year, by the Dr. Frank Holtz, this paper was published by its use in ROP. And I like, this retinoscope. I'm not sure whether it's commercially available yet, but, I read both the papers. It looks quite exciting in terms of the montage and the other facilities. MIO, recently launched by the Keeler, again, a smartphone-based device, no scientific data yet. So predominantly, most of the devices, they work on the basis of the indirect ophthalmoscopy. I have not used Paxoscope and retinoscope and MIO, so I will stick on the presentation on RetCam, which I know and which we have used. So this is, again, the same principle here. You have a smartphone, you have a 20 diopter lens, or you can use other lenses like 40 diopters, you can use 60 diopters also. And the way we have designed it, which differs from the other devices, that you are not stuck to any single phone. You can use multiple phones, because that's where the problem is. Sometimes the devices are so specific to the phones that they get outdated really fast. And if you look at the weight of the device as such is 100 grams, but yes, a smartphone and the weight of the lens comes into the place. It has 0 maintenance. It is non-contact. You can do a peripheral imaging. So essentially, whatever you want and you image with the indirect, you can have an image with this device. Wide field imaging. Now, this is the session on the wide field imaging. So if you would ask me that, whether these devices are real wide field imaging devices, answer is yes and no. Why no? Because you cannot have image, one image where you can have, real wide field. But answer is yes. In, different ways you can achieve it. For example, one way is you can use the different kind of lenses which can capture a little wider field. And second is you can do a montage. So montage can also give you that kind of picture. For example, this is the paper that we published. And in this particular paper, you can see the change in the field. So you can reach up to the 90 degree of the field with the higher dioptric lens powers. And this is the montage. I like this picture again from the retinoscope. You can do a montage. There are a lot of softwares available, but if you really want, the Retina i2K is the one which is a professional body in montage, and they really do a good montage. Imaging technique, I think it's everybody knows. So to emphasize, the single hand operation is possible, and you can do the indentation with the other eye. And as the way, if you are good in the indirect, and which we all do, so I think it's easy as far as the learning curve is concerned. These are few of the examples. So you can see that you can really go periphery, and all those telltale signs of ROP you can capture with this device. These are all published images, and I should thank to all the collaborators for that. Again, on the posterior pole, it can help you to image of the posterior pole. So, it helps in the referable ROP kind of setup in terms of the telemedicine. This is again a picture, again published. You can actually go up to the ora serrata and pars plana. You can see here the pars plana. It's a case of the peripheral uveitis. And now the question is, you have images coming in, but there are challenges, and we try to find those solutions of those challenges. So first challenge is stability. So this is a non-contact device and handheld device. Anything which is handheld and non-contact, it's like, you do not have the tripod. So that's where the stability issue comes in. But to really, really solve that issue, you can have some techniques. For example, you can have the palm support over infant's forehead, or you can actually rest the part which is where the lens fits in on your volar aspect of the palm, and you can just drag it back. Learning curve wise, this is the paper that we published in terms of what difficulties that we have. So learning curve wise, there was real variation from 2 days to 2 weeks, and the average was approximately 7 days. Artifacts, yes, you have a different kind of artifacts. So we divided in this particular paper artifact in 2 categories. One is the consistent artifact, and one is the non-consistent artifact. If you look at the consistent artifact, these white 2 dots, those were the consistent, because those are the Purkinje's image coming from the front and the back surface of the lens. Whereas if you see these parallel lines, they are basically tube lights in that room, and you see a little bit of the grainy, some dots, shiny dots, that is the dust which is there over the lens. So if you can really get rid of all those non-consistent artifact, but consistent artifact, they are there until unless you place any kind of filter in place. So till date, I would say, as of now, we would not call it a screening tool. Rather, it's an imaging tool, a cost-effective imaging tool for the ROP and other pediatric imaging. Wide field imaging is definitely possible, even up to the ora serrata and the pars plana, with some learning curve. And the future direction-wise, a smartphone-based contact imaging is not yet tried. I would say, that might be something which can help and on the NICU for the nurses to take the pictures. If you have something, directly contacts and just give the posterior pole at all. You should have the little bit of the hands-free imaging for the better stability. Artificial intelligence, couple of papers are already published in terms of, diagnosing the plus disease, especially with the artificial intelligence. So I think that would be easy to incorporate as far as the smartphone imaging technology is concerned. So thank you so much once again, and I cannot stop this presentation without thanking all these people around the globe. They have been using RetCam. They've been sharing the images. They've been sharing the inputs. So a big thanks to all of them. Thank you so much for having me here.
Well, I don't know quite what to say. That is fabulous. That's just amazing to know that you can do that with a smartphone. Ashish, as you were speaking, my phone was blowing up and people are saying, how can I buy the MI RetCam? Is it for sale?
It is. Since 5 years. It is in 49 countries already.
Fantastic. And what about the other adapters? Are they for sale?
Actually, Paxoscope was on sale, but recently, last year, what we have heard was it is companies being sold to someone and they are not going forward with it. But I like this Retinoscope. I gone through a couple of papers. Those are fantastic. It's even much portable and it stitched the images really well. But I'm not sure whether that is commercially available yet.
Okay, all right. So Lottie, I think there's a couple of questions that we don't know the answers to ourselves. We'll see if the panelists know the answers to any of these questions. Would you like to share those?
Yeah, one is, no, sorry, just a sec. I was wondering about the, Dr. Subhadra, have you tried the retinoscope?
No, but I have tried the RetCam, MI RetCam. Yeah, it's pretty good. The only issue is it's all these smartphone based, and there are many smartphone based. Even the normal smartphone you can use, but this gives you a handle. The problem is that they're all indirect ophthalmoscopy based, which means it has to be usually done by a retina person who knows indirect ophthalmoscopy. Otherwise, it gives very good images. So it's an additional tool to your indirect ophthalmoscopy, where the indirect you cannot, document the photographs. The parents cannot see what you are seeing. So here you put it on the parent's smartphone, and they can actually see what you are seeing. So that's the usefulness of the smartphone.
And we were talking about the image sharing. What happens? We have an application. So what happens? Immediately you take a picture, and you can share everywhere. You can directly share on the WhatsApp of the patient. So patient gets immediate gratification. You do not need the sophisticated tools to really transfer the images.
Yeah, so as we said, that would be country specific. In some countries, it may not be allowed, but yeah.
That depends. I mean, right now, during the pandemic in the USA and lots of countries, I'm sure you could do that. But again, country specific. But it makes life very easy to explain. Lottie, did you find that question? I've just found it. Somebody says, do you have experience with this SUOER 8000 ROP camera? I've not heard of it. Anyone heard of it? Sour? I haven't heard of that. And then the other question was, what about...
Is it sweet?
Sorry?
It's sour.
No. It says, it's
okay.
Sweet. Very good. That's a bit early in the morning from your jokes, but thank you. Somebody says, what about the non-IR ODOX? I haven't heard of that either. Has anybody heard of that? So whoever's asked that question.
Yes.
Yes,
ODOX is again, the same platform, but what they use is a 3D printer.
Yeah.
So 3D printing technology on the same principle of the indirect.
Mm-hmm.
Same principle.
Okay. All right. This is amazing. I had not heard that. Question for you, Ashish. Could you use a 3-mirror lens or a wide field lens with the MI?
We could use 28. We could use 40. We could use with 40 you really have a good field. But as you keep going up in the lens wise, the edge artifacts keeps increasing. Okay. So because MI RetCam yet is an open system, if you really want to get rid of the reflections, edge artifacts, you need to have a polarizer in place, which you cannot do in an open system. So we are working on it. Means as on a contact system that I told you at the end, where the aim is in an NICU, as soon as the nurse puts it on the cornea, you should see a posterior pole, so that at least we create a system, so that referable ROP at least can be taken care of.
Yeah.
Has anybody on the panel tried the Vista View Walk for ROP or other retina disorders in children? Anybody on the panel use that lens from Volk? No? Okay, so that's interesting. So let me just while we're trying to get through, because time is running out. However, this is really interesting. I just want to share this with everybody. I'm going to share my screen. I always find this part of the webinar really interesting. Look, this is how old are you, and you can see that we cover all the ages. We haven't quite hit the school children at the moment, but there's quite a panel there of interest. And I think one of the things that strikes me, I'm just going to go through the Menti questions. So the Menti questions, very briefly, we've done the how old are you? 81% females, 19% males. And the only continent that we don't have anybody listening or watching is Antarctica. which I'm very pleased to hear about. And it says, what do you do? 87% are pediatric ophthalmologists, 6% adult ophthalmologists, and 6% orthoptists. When you do fundus imaging, do you dilate the child? 23% sometimes do, 70% always dilate. So I'll come to that question in a minute. At your practice, which of the following machines do you use for wide field imaging? 9% Phoenix Icon, 37% RetCam, 1% Trinetra, 15% Optos, 4% Clarus, 15% smartphones, 4% any of the above, and 15% none of the above. Can the panel comment on that? Can we say that wide field imaging should be part, no matter how you do it, even if you're using a smartphone, which I think is superb, and a free lens, you might not have the adaptations that Ashish is talking about. Wide field imaging should be part of a pediatric ophthalmology assessment, at least sometimes. Can each panelist give me their opinion on that statement? Lottie, let's start with you.
Well, in my opinion, I think it's a great tool for having a base. So if you get a patient in with some sort of disease, it's wonderful to have the baseline pictures. But I don't think it's a necessity to have wide field photos of everyone. I think you must be able to trust your abilities as an ophthalmoscoper still.
All right, let's go around. This is a really interesting question. Jamila?
So I think it's important to incorporate wide field imaging in your practice. Many examples in my fellowship here, we were able to pick up different pathologies in patients. Children sometimes are not cooperative for detailed fundus exams. So I think if you can incorporate in your practice imaging, I think it's pretty important and useful.
Subhadra?
I would say that, the fundus photography should be done in every patient who comes. Because, we think we've seen something. I would say adults, children, everybody. And that's the way to go. Very soon our clinics will be, the patient comes in, somebody takes a picture, and then they come to you. And, because you document, and especially in children, they have a long life. You really want to know what it was last time. Did I miss something? Was there something there? I have so many stories where patient, I showed them a break and I said, I'm going to laser this break, which was on the photograph. And then I found another break and I lasered, and the family was so upset. They said, how can you laser something which was not on the photograph? So you try to explain, but I think documentation of every patient's retina for me would be so nice if we could do it for every patient, because we don't know what they develop later in life, whether it's children or adults. Yeah.
Ashish?
Have it if I can afford it.
Okay. Dominique?
Well, I think really we have new devices, very better definition, and if we can use it, we'll use it. And I can understand that it couldn't be every consultation, but I think it's at the time it's a plus. And I was amazing photos by Ashish just with a smartphone, so it's incredible and it's very nice. But it's time consuming also, and so I really appreciate your work. And so go on, Widefield.
Yini, what do you think?
We laugh saying doing every patient because the money's just not there. But if you look at our adult retina clinics, they're all getting OCT, IVFA,
right.
image. It's just the norm. So after hearing everyone else talk, I agree with everyone's comments. There's so many options even from 5 years ago, but I think we really need to push the powers that be, hopefully they're maybe listening to our talk, that children should have just as many. If you have the right people in place, it should become the norm. I agree with you.
Yeah.
So we're already 2 minutes over. So I've got a couple of other things, housekeeping things to do. I want to tell everybody on this panel that this has been one of the most informative, new information, innovative webinars I have had the privilege to be part of. I want to thank every single person. My own opinion is that every child once a year should have a wide field image. No matter how you can do it, I think they should have it. I have picked up pathologies that I missed myself. And if you want to know, get someone to do an indirect ophthalmoscopy on you with a headset and see how uncomfortable it is, because it is awful. It is awful. And getting an Optos or a Clarus, or even if it's a baby, one of the contact ones, I think is really going to help. I'm going to just share my screen one last time, because I do want to do some housekeeping. Would you like to say some words, Lotte, while I get my screen up?
Well, I also think it's been very, very informative and great talks, and very happy to participate in this, because it's really a very interesting field, and very, yeah, will be much larger over the next years. So, yeah.
So, you know, this is unprecedented. I am getting our organizers saying, go over. This is a great webinar. We are rising in numbers. Right now, we have just gone well over 3,000 live viewers. So we are going to go on for a few more minutes. This is something that was sent to me by David Granite. Of course, he has highlighted his name. David, if you're listening, I'm sorry to kid you. This is a really good paper. Basically, David showed in this paper with his collaborators that the wide field digital imaging picked up pathology that was not picked up by indirect ophthalmoscopy. So if you want to speak to your hospital administrators, that's where it is. Now, I know there are parts of the world where you're not going to be able to have this technology at the moment, but that's where people like Ashish are showing you that you can still, with a smartphone, get some sort of imaging done. So Ashish, thank you so much. Once again, please put these in your schedule, in your diaries. These webinars are your webinars. The WSPOS is only the WSPOS because of you. I want to give this a shout out. Chianti Darusman is one of our Connectivity Bureau members. This lovely man down here designed, he has trisomy 21, very intelligent guy, designed these images. Zafscarf have made these into surgical caps. Everybody who buys one, some of the money goes to POTADS. POTADS is a group in Indonesia for parents of children with trisomy 21 to help build their confidence and help them bring up their children to their fullest potential. If you want to purchase them at Zevscarf on Instagram or Facebook. Remember, we have a Facebook page. We got the international listserv with David Granite running that. That's his email address. We're a free member society. If you want a certificate of attendance, please email program@wspos.org. I'm going to thank everybody, then I'm going to come back to the panel. We have a YouTube channel. If you sign up to the YouTube channel, you'll get plenty of notice about all our webinars. The next one's on the 23rd. It's about ocular surface disease in children. I've got to thank Entod for hosting this. Phoenix Icon, thank you so much for your sponsorship. When we finish, there will be a video. Please watch that. It's really interesting and very helpful. I've got to thank Dara McCafferty, Akila Acharya, Emma Hester for our backroom admin staff. And I'm going to stop sharing there, and I'm going to come back to the the panelists. If you wanted to say one thing that you thought was a pearl, what would you tell the audience? What's the one thing that you'd like to impart? Whether it's what you use to dilate babies, whether it's any tip that you think would help the audience. Subhadra, you are the most experienced and easily the person who I think has the most knowledge about this. What's your tip?
Yeah, I think one thing we didn't touch in the seminar was about the after-sale service. Be very careful, because there are companies who will not give you the service, and there are some which don't need a service. So definitely look at that and think about it. The different machines cost differently, but the fundus photography cost is the same. Down the line, do you want to charge different for different machines? Just think about it.
That's a superb question. And that brings, somebody said that they had a RetCam 2, which doesn't work, but they can't get parts. The reason for that, for the person listening, RetCam technology was owned by Clarity. They sold it to Natus. And I think that's where the problem comes. And what Subhadra is saying is, speak to your colleagues around the world. WSPOS is a network for you to speak to people, find out what the post-sales care is like. Do not go where the post-sales care is lousy. That's really important. Ashish, any other tips?
I would say, as I would go with Dominic, what you said, that I think we are in a technological era. And the way the camera technology is going ahead, I think we are going to find real cost-effective solutions, very, very portable. And so I think as a clinician, that's where the difference I see. As a clinicians and the engineer, we should have the connect with both. That's where we can bring out, in the next decade, real good technology. Because if whatever we say, whatever is available, ultimately cost is the factor to take it to each and every one. So ultimately, unless we work on that part, I think we won't be able to provide the symmetrical care.
Yining?
Everyone's made great points. I just say keep trying. If you're not alone, reach out to your photographer friends, people in this community, and it's actually easier than you think.
Dominique?
I should say wide-angle retinal images are better diagnosis and better for the children.
Jamila?
I would give an advice to invest in an imaging team. These are the people who are close to the patients while taking imaging. And if they get adequate training, you will have a good quality images that will affect how you manage your patients.
So for everybody listening, I know there are lots of questions. I'm going to come to lots.